How do we make that advance? There we go. So we'll start with something very obvious. It sounds like you've got the right machine. I assume you have the VN 500 ventilator, and that's a great tool. But having a great tool is not enough. Knowing how to optimally use it obviously is the other part. And in other words, it's not just the tool, it's the carpenter that's wielding the saw and the hammer. So we'll try to address some of those issues. And of course, what we're all trying to do, and Jack let me know that one of your goals, is everybody's goals, is to reduce the incidence of chronic lung disease. And we all know how quickly that can happen, particularly in the vulnerable preterm infant, where that nice healthy terminal air sac gets devastated in a matter of hours to days, with a complex process that's usually initiated by some form of biophysical injury that leads to influx of activated neutrophils that release a whole bunch of markers and mediators of lung injury, and the whole process can evolve rather quickly, as you know. And of course, it can even start in utero with intrauterine infection. So here we are trying to prevent this bad thing from happening. Turns out we can't always succeed, but I think what I want to emphasize here is that BPD, the eventual pulmonary outcome, is really a function of many factors. Ventilation is certainly an important one. I don't know if you can see my pointer, but I'll try anyways. Ventilation is certainly an important one, but lots of things affect fetal lung development already. I mentioned choriamnionitis, neonitis, but having oligohydramnios, having severe growth restriction, all impact on eventual pulmonary outcome. But of course, that predisposition is greatly modified by things like our initiation of air breathing after preterm delivery, and of course all the other factors listed above the line here, ventilation and oxygen exposure and infection probably being the major ones. There are a few things we can do to mitigate. But the message here is this has to be a package deal, right? There's not just one thing that's going to make BPD go away. It turns out that volume-targeted ventilation certainly has a significant impact, but everything else has to be done optimally as well. So we'll briefly mention some of the other aspects. And again, lung protective ventilation begins in the delivery suite, and we all know that our preterm infants have a variety of challenges in establishing functional residual capacity and initiating air breathing, clearing lung fluid, and those are listed on this slide. And so we've learned certainly that we need to do some things very quickly and very carefully in the delivery room. It is very clear that these babies do require some form of distending airway pressure to facilitate lung aeration. This is a nice example of this is a phase contrast radiograph study that shows how if you are using, for example, a self-inflating bag with no effective PEEP, that even after 20 inflations, there's very little aeration, air being white in this image, even after 20 cycles, and there's essentially no FRC. Whereas with application of reasonable end expiratory pressure, the FRC is established much more rapidly and lung inflation is much more uniform. There's been a lot of attention paid to how to optimally facilitate aeration of the lungs after birth in preterm infants. I was one of the co-conspirators in the SAIL trial that was published a couple of years ago, and was a great disappointment, especially for the Europeans who had adopted sustained inflation as a widespread practice, because that study did not indicate any benefit and in fact a possible harm. So we're still working on that. There's another trial soon to be underway that's looking at titrating PEEP as a more gentle and tailor-made strategy, but that's for another time. So, of course, we're talking about ventilator-induced lung injury, and we're not going to talk about all the ways to prevent the need for mechanical ventilation. Suffice to say that obviously if we avoid mechanical ventilation altogether by effective use of non-invasive ventilation, we are ahead of the game, although the most immature babies obviously still require positive pressure ventilation. So the topic is volume-targeted ventilation. Volume guarantee has become pretty much the prototype. So why? I will briefly try to convince you that it's volutrauma, not barotrauma we should be talking about. And I think most of you already accept that concept. We all know how easy it is to inadvertently overventilate babies, and we know that that's bad for the brain and, of course, also for the lungs. And so, of course, in the PICU and in adult world, they use volume-controlled ventilation. It doesn't work so well in small preterm infants. We tried it back in the early 1980s, and it didn't work so well for reasons I'll explain in a moment. So lots of data, not new data. This has been around for decades, this information that it does appear that pressure, not volume, is the most critical element in lung injury. This is an example of one of the many studies that showed that. Here they took a bunch of small animals, I think they were rabbits. They ventilated them with progressively higher inflation pressure. But what they did differently, there were two groups. One group, the open bars, the chest wall was free to move. In another group, there was a plaster cast placed around the thorax and upper abdomen to restrict chest wall motion. So there was no injury. And they looked at capillary filtration coefficient, which is a crude measure of acute lung injury, essentially lung edema. At 15 centimeters of pressure, there was no lung injury because that pressure does not over-distend. At 30 centimeters, in these animals with healthy lungs, there was already a significant increase in acute lung injury. In the group where the chest wall was free to move, no difference, no change from baseline where the chest wall motion was restricted. It's not surprising that at 45 centimeters of peak pressure, there was a huge increase in acute lung injury, lung edema, where the lungs were free to expand and overexpand. What is surprising that despite that same high pressure, when the chest wall was restricted, there was no acute lung injury, at least as measured by the capillary filtration coefficient. There are a bunch of other studies indicating the same conclusion. And what this leads us to understand is that high peak inflation pressure results in lung injury only if it results in corresponding overexpansion of the lungs and this beaking of the pressure volume loop. When high pressure is needed and is appropriate, does not lead to overexpansion, you probably don't get that sort of lung injury. So I'll cut to the chase and go straight to the most recent meta-analysis. There have been several over the years. This one is the most recent Cochrane meta-analysis that included a whole bunch of additional studies compared to the earliest ones. And what this shows, of course, is some pretty impressive impact. Now, the combined outcome of death or BPD did not reach statistical significance because the confidence intervals cross 1, as you can see here in the middle column. But the point estimate suggests 25% reduction in that combined outcome. When looking at bronchopulmonary dysplasia at 36 weeks alone, there is a roughly 25% reduction, and this is now statistically significant, with a number needed to treat of 8, which is really quite impressive. Severe intraventricular hemorrhage was reduced by almost 50%, number needed to treat 11. Periventricular leukomalacia or severe IVH was similarly reduced by about half. Same number needed to treat. Pneumothorax was reduced by half. And hypocapnia was also reduced by approximately 50%. And there was also shorter duration of mechanical ventilation. So these are pretty impressive numbers. One would therefore wonder, why isn't everybody using volume-targeted ventilation? And one of the reasons is it's not as simple as it seems on the surface, and we'll go over some of the challenges when it comes to understanding how to make it work optimally. But before we do that, back to some basics for anyone who needs a bit of clarification. What we have traditionally done in the NICU, as you well know, is using pressure-controlled ventilation, where pressure is the independent variable. Here we have a standard pressure volume loop in green, that a certain inflation pressure results in a certain tidal volume on the vertical axis. Okay, in this instance, the lungs seem pretty stiff. The tidal volume isn't that great. So if now compliance improves significantly, maybe we gave surfactant, maybe we recruited lung volume, the tidal volume will go up. The pressure remains the same because pressure is, in this instance, is the control variable. And so tidal volume increases, and that may be a good thing if it was inadequate to begin with, but if it was in fact appropriate and now compliance has improved, the tidal volume might become much larger and might become too much. So that's pressure-controlled ventilation. With volume-controlled or volume-targeted ventilation, and I'll explain the difference between those two momentarily, volume is the independent variable. So volume is fixed here on the vertical axis. Volume is fixed. That's the primary control. And the ventilator generates whatever pressure is needed to achieve that tidal volume. The red loop is our compliance loop, pressure volume loop. If compliance improves, the pressure needed to generate that same tidal volume drops, but the tidal volume remains the same because it's a primary control variable. And so perhaps that's a safer approach, right? Because we want to control pH and PCO2. And I hopefully convinced you that it's excessive tidal volume that you want to prevent. So why not use the standard volume-controlled ventilator that our colleagues in the PICU and adult ICUs are using? The problem with volume-controlled ventilation is that what it controls is the tidal volume that's injected into the proximal end of the ventilator circuit, back at the machine. That's where it's measured. That's where it's generated. And of course, it's not a big problem if there is a large patient attached here, but there always will be some loss of that tidal volume to compression of gas in the circuit and stretching of the elastic circuit. When there's a small baby attached here whose lung volume is only a fraction of the tidal volume of the volume, internal compressible volume of the circuit and humidifier, then majority of the tidal volume injected into the circuit will be dissipated. And then there is the issue of having uncuffed endotracheal tubes with variable leak. And so it turned out when we tried this back in the day, it didn't work so well. You had to dial in some like 50 mLs and baby might get 10 ml actually into their lungs. So of course we've all reverted to what we know and love, pressure controlled, pressure limited, intermittent mandatory ventilation, which is in its basic functionality nothing more than a mechanical T-piece resuscitator. There's an expiratory valve, and when it's open, there's continuous flow of gas in the circuit if we're in SIMV mode, for example. And the patient can breathe in and out of the circuit. There's a PEEP valve maintaining some descending pressure. And when the ventilator cycles on, the expiratory valve closes, the circuit's pressurized, and gas enters the patient's lungs in proportion to the pressure in the circuit and the compliance of the lungs. And we don't care that there's a large leak around the endotracheal tube, because there's plenty of fresh gas to compensate. And so it was the ability to easily ventilate in the face of large leak and the conviction that many still cling to that pressure is the dangerous variable that we should be afraid of led us all to embrace pressure-controlled ventilation as the primary mode. The problem here, of course, is that when compliance improves, as I showed you earlier, that tidal volume can rapidly become rather excessive. So there are important differences between volume-targeted and volume-controlled ventilation that you need to keep in mind. So volume-controlled ventilation is volume-targeted ventilation, VG, volume guarantee, is in fact pressure-controlled ventilation, but it automatically targets a delivered tidal volume by adjusting the inflation pressure breath to breath. So basically it starts with an initial tidal volume generation. That tidal volume is measured. It's compared to a target tidal volume. And then depending whether that measured tidal volume is less than, equal to, or more than the set targeted tidal volume, the machine will adjust the inflation pressure, up or down, or leave it the same to maintain a target tidal volume. It is still pressure controlled, but with volume targeting. All right. So I just want to briefly pause and talk about something that's been taking the country by storm to a degree, and that's this NAVA thing. And in Europe, they have something called proportional assist ventilation, which is a similar principle. So how does this NAVA work? It stands for neurally adjusted ventilatory assist, and it seems like maybe a good idea in older subjects. It takes an opposite approach to volume targeted ventilation. So then electrical activity of the diaphragm is measured by an electrode, and pressure is generated in proportion to the patient's effort as reflected by the electrical activity. So when the patient breathes only a little support is generated. Whoops, I keep touching very sensitive key here. And when the patient breathes more vigorously, more tidal volume is generated. It assumes mature respiratory control. Volume-targeted ventilation, VG, takes the opposite approach. It understands that the preemies have immature respiratory control. And so when the patient hypoventilates, it generates more pressure to maintain a stable tidal volume. And when the baby briefly hyperventilates, it backs off. Preemies, of course, tend to breathe more like this on the right side of this screen, where there are brief bursts. There's a lot of periodic breathing. There are brief periods of apnea or hypoventilation. And when you take this positive feedback approach that NAVA does, you will exacerbate or exaggerate these fluctuations. And here's an example of that from an actual publication of one of the originators of this approach. They're very proud of how closely the machine tracks the patient's respiratory effort as if that were a good thing. Well, in adults, and they admit this, there's much more stable respiratory effort and therefore stable respiratory support. But look at this little preemie who's hypoventilating, getting not much help from the machine, then breathes a little bit better for a while, getting more support. Then another period of hypoventilation with no compensation by the device. And then brief burst of very strong inspiratory activity with corresponding large pressure being generated by the machine. So this to me seems like not the best way to ventilate preterm infants. So I'm arguing that volume guarantee, which works to smooth out this irregular respiratory effort, is in fact a better approach. So I showed you some of the data already from a meta-analysis and there are other studies that I didn't refer to, but we know that that volume-targeted ventilation maintains a relatively constant tidal volume. It's not completely constant, which is a good thing, because completely monotonous ventilation leads to atelectasis. So there are some fluctuations. Why? Because the patient's respiratory effort is inconsistent. So it's always perturbing the equilibrium. We'll get back to that. Most important, though, is the fact that it prevents overdistension, volutrauma, and inadvertent overventilation when we do things that improve lung compliance. Give surfactant, we help the baby recruit lung volume, optimize lung inflation, which improves compliance, clear lung fluid from and again, that improves compliance. It also automatically lowers the pressure. So, the machine doesn't wait for the next blood gas. It doesn't wait for morning rounds to make a decision about weaning the pressure. It's not afraid that the boss will yell at it for making the wrong decision. It just does what it's programmed to do, and that is why there is shorter duration of mechanical ventilation with VG. It weans in real time. And it compensates for that variable respiratory drive that I showed you. So these are, again, to reinforce some of the obvious advantages, which are now clearly documented by published evidence. Now, controlling the tidal volume is absolutely important, but it's not the full picture. The other part that I'm trying to impress on you is making sure that that tidal volume is evenly distributed throughout an open lung. So open lung strategy applies to conventional ventilation, not just high frequency. Why is that important? Well, here is why. We talk about atelectasis trauma. We think of RDS as a homogeneous lung disease. We call it homogeneous lung disease, and it looks homogeneous on a chest radiograph, which unfortunately compresses a three-dimensional structure, the lung, into two dimensions. When you cut the lung across with an MRI or CT scan, you will see that there are gravity-dependent differences, with much of the atelectasis located posteriorly. Now there's research tool called electrical impedance tomography that can give you these images, not quite the same resolution, but similar images in real time. And you then see that there is aerated lung anteriorly, very inhomogeneous, in fact. And so that's in cartoon form depicted here. And why is this a problem? The problem is that when you apply push a tidal volume into a lung that has this amount of atelectasis, guess where that tidal volume will go? It will go preferentially into the anterior non-dependent aerated portion of the lung. This has to do with Laplace's law, which you all remember, that tells you that the pressure needed to distend a structure such as an alveolus or a balloon is inversely proportional to the radius. So these small collapsed alveoli have a substantially higher critical opening pressure before they will accept any aeration, and the pressure needed to overexpand the already aerated alveoli or air sacs that have a larger radius is of course much lower. And this is why the bulk of the tidal volume will enter here. There's other other components to atelic trauma, including surfactant inactivation in the alectatic portion, shear stress on the boundary, and other elements. But this is, with respect to volume targeted ventilation, the critical point. If you're ventilating with a tidal volume of 5 per kilo, which should be safe, but you're ventilating only a third of the alveoli, you're going to have volume trauma. And there's actually experimental evidence to support that this is in fact true. So here is a study that's now a number of years, 15 years old, that ventilated with two different, the lavaged animals were the ones that there were issues, obviously the healthy ones not so much. And they were gentle ventilation, they had more aggressive ventilation. But what's important here is that the dependent portions were relatively protected. It was the non-dependent, the anterior portion on that image that I showed you, that bore the brunt of lung injury, as depicted by these various, this was a histologic score. And when they looked at a bunch of cytokines, that clearly, again, there was significantly more biochemical markers of lung injury in the non-dependent portions of the lung. So this is not just theoretical, this is in fact what's happening. So what do? We need to get the lung recruited. How do we do that? Well, you can do it different ways. You can do it with oscillatory ventilation, but you can equally well do it with conventional ventilation. What we're trying to do is get away from that, from the inflation limb of the pressure-volume relationship, where compliance is poor, and whoops, I keep doing this, and where you're going to have a high oxygen requirement, you're going to have a lot of atelic trauma. So now moving in this cartoon left to right, you need to increase the distending pressure. You need to exceed the critical opening pressure of these alectatic alveoli. And in doing so, you will transiently overexpand the anterior, the aerated portion. That's inevitable. And if it's only for a limited period of time, does not appear to result in significant damage. The important thing is that you don't want to stay up here. The pressure needed to recruit the alveoli is more than the pressure needed to sustain that recruitment once the lungs have opened up, because now with a larger radius, it requires less pressure to maintain that inflation. We didn't realize this for many years, and lung recruitment was usually an issue with or employed with oscillatory ventilation, and the mantra always was, go up, go up, go up. And once you got the lung open, good, don't touch the mean airway pressure. And of course that was wrong, and that's why oscillation acquired a bad reputation for being terrible for cardiac output. Well, the reason was we were overexpanding the lungs. We now know we need to back down on the expiratory limb of the pressure-volume relationship, try to find the sweet spot just above the critical closing pressure. And that's depicted here. How do we find that? Well, there's some details to that. Basically, you need to go up till the oxygen requirement goes way down. And as you then lower the mean airway pressure, whether you're doing it with the oscillator or you are manipulating end expiratory pressure or PEEP with conventional ventilation, you find a point where oxygenation begins to deteriorate, and that's kind of your sweet spot. You may have to reopen the lung and then go back to that. So don't want to stay here. Want to get down to this normally inflated, not overexpanded lung. You can never achieve complete uniformity, but it's important to try to find the optimal sweet spot. So we'll talk a little bit more about what it takes to maintain that lung inflation. This is a cool study from more than 18 years ago that looked at, they used scanning electron microscopy to look at subpleural alveoli. They could see individual alveoli during inspiration and expiration. And they were able to measure and calculate how many remained open throughout the cycle and how many were collapsing. And that was a way to determine what level of end expiratory pressure was needed. And so here are the data from this study. So they lavaged these lungs. So injured lungs, there's a lot of atelectasis, right? So they were not even opening very many alveoli at that point, and there was not much difference between inspiration and expiration. That's this delta, is this difference between peak inflation and end expiration. Well, there was hardly anything open. So then they do a recruitment maneuver, open up the lung, and so there's lots of alveoli per open during peak inflation, but and there's very little, while that sustained inflation is maintained, there's very little change throughout the cycle. When they then begin ventilating with a relatively low end expiratory pressure here of 5 centimeters, there are many fewer open alveoli during the inspiratory phase, and a large difference between inspiration and expiration, meaning alveoli are collapsing. So going back up to PEEP of 10, now more alveoli are open again, and they remain open throughout the cycle. So of course, we can't do that in our babies, but experimentally, this was a nice way of demonstrating the importance of adequate end expiratory pressure to maintain alveolar stability and avoid that opening and closure, recruitment, de-recruitment, which we know is very damaging. So what is the right PEEP? That's a very important question that we all struggle with. The important thing to appreciate is that there is no single optimal PEEP for all babies. Not all babies are the same size. You know, some review articles tell you, well, if the baby is less than 1,000 grams, PEEP should be this. If it's over 1,500 grams, it should be that. That's really false. That's really not based in science. What PEEP needs to be based on really is individualized care and titration. We need to titrate it to optimize lung volume. How do we do that? How do we know the lung volume is optimized? Lung volume is reflected by ventilation perfusion matching, right? And that, of course, is reflected by oxygen requirement. So the Dutch have published some data with oscillator ventilation about how they go about recruiting the lungs, and they do that before they give surfactant. And so it's called oxygen-guided lung volume recruitment. But basically, you can do the same thing. Gianluca Lista published a small study from Italy that did the same thing with volume guarantee conventional ventilation. You go up on your descending pressure by increasing PEEP in case of conventional ventilation. If your oxygen requirement is greater than 30%, you want to open the lung. That greater than 30% suggests a fair amount of VQ mismatch. So you go up. Small increments. He went by 0.5 centimeters of water. We generally do 1. And if your oxygen requirement remains high, you go up some more. And you may have to go up to 7 or 8, rarely more. And once the lung opens again, we need to back off. So once we've titrated the PEEP up until the FiO2 comes down to less than 30%, then you reduce it. When the lungs open, as we know it is, when the FiO2 is down around 21%, we should not leave the PEEP up at where we had it before. I find this in my own unit. People forget to wean the PEEP. They go up, that's great. We don't like PEEPophobia. I understand you're relatively PEEPophilic, which I greatly appreciate. So some of this talk was preaching to the choir. But PEEPophobia, too much, of a good thing can cause problems as well. So, know when to back off. Now, this is relevant to the acute RDS situation. In a different circumstance, your older baby who has just gotten extubated from relatively high support, with the aid of the DART protocol and, still needs a fair bit of oxygen. BPD babies need a whole lot more PEEP. That's a different population. We don't have time to go into the details here, but, you often need quite a bit more. But PEEP has to be titrated. It has to be individualized. There's no one that fits for everybody. All right. So back to volume guarantee, and we're going to talk about some practical things now. I have been somewhat frustrated by the fact that in this country, at least, we're relatively slow in adopting volume-targeted ventilation. Some parts of the world, it's universal. Scandinavia, almost universal. Australia and New Zealand, universal. Canada, they're very good about it. I'll show you. I won't show you. I'll tell you that they are almost all using it. In the US, it's not so much. And there's lots of reasons and excuses. A lot of people don't have the right devices. And a lot of people, it turned out, didn't have a real good appreciation of how it works and what you need to do to make it work. But one of the challenges with volume-targeted ventilation is, can we accurately measure tidal volume with uncuffed endotracheal tubes that have a significant leak around them? And there's this is an example of how the measured tidal volume deviates from the actual delivered tidal volume as you progressively go up on the leak on the horizontal axis. And you can see in those gray triangles that the inspiratory tidal volume starts to go up really steeply when you get a really large leak. The expiratory leak is less, but it's still there. And of course, it's driven by PEEP. So if you're using a higher level of PEEP, you'll have more leak than what's demonstrated here. But these measurements actually were able to be used in an algorithm incorporated in the VN500, which now has really effective leak adaptation, leak compensation. They've always had the leak adaptation, but now you have the ability to turn on this leak compensation. You should always have it on, as far as I'm concerned. The company, for some reason, gives you, I know why, it's complicated. Some people wanted it that way, but you set it one way and it stays that way. But this is how it works for anybody who is wondering. So if you have, let's say, 33% leak during inspiration, so 6 ml might be going in, but a third of it comes out during the inspiratory phase, and only 4 mLs actually enter the patient's lungs. Now, as you recall, VG uses the exhaled tidal volume to regulate, and the reason, as we know, is that there is less leak during the expiratory phase. So in this case, 4 ml entered the lungs, but there is some leak if you're using enough PEEP, and in this case, 1 ml escapes. So the flow sensor measures a 3 ml tidal volume, but actually the baby got 4. So you have a fairly big leak here. And of course, what would happen is the ventilator would go up on the pressure to try to compensate and try to reach that tidal volume of 4 ml based on faulty data. But this very sophisticated algorithm that's incorporated in the device calculates that the baby's lungs actually saw 4 mLs and discounts the fact that it's measuring 3. And so the reason for not using volume-targeted ventilation because of uncuffed tubes with a large leak no longer applies in the modern era. And this, I'm not going to spend time on it, but if you have the leak compensation on, your waveforms are reflecting no leak, which actually I don't like. I'd like to be able to turn that piece on and off. So I want to see the leak visually, but here it's displaying the corrected tidal volume. This is in this box here, but it's measuring inspiratory tidal volume of 6.8 and exhale tidal volume of 3.5. So big leak, 70%, but it's compensating very accurately. And I can tell you that it compensates incredibly well up to leak of almost 80%. So not a problem. All right, let's talk about, all right, so we've got a baby. We're going to put him on VG. So yeah, we'll obviously pay attention to the baby's underlying disease process and see what's going on, and we'll get back to some of those details in a minute. You pick some settings, and what people used to do is skip this little part, and go straight to getting a blood gas an hour later. Well, that's not optimal care, right? We have a lot of information the baby can give us because unlike in the PQ and IC and adult ICU, we don't paralyze our patients. So the patient can give us clues as to whether or not our choice of settings was appropriate. So it's really important to reassess whether the baby is responding appropriately and only get a blood gas to verify, to document that everything is good. I tell my fellows and residents, you should never get a bad blood gas. But they still do, but shouldn't. So what can the baby tell us? A lot. If we picked a tidal volume that's too high, the baby will probably stop breathing, right? So if we got this baby and we, let's say, converted him from whatever he was on to VG, and the baby was breathing along with the ventilator and then stops, we probably took away their respiratory drive. Oh, and by the way, it is the pH, not the PCO2, that drives the respiratory effort. And sometimes in babies who may have a metabolic alkalosis or metabolic acidosis, we get faked out. People keep looking at just the PCO2 and increasing or reducing the support and not recognizing that they really need to pay attention to the pH. And these very preterm babies who invariably have some degree of metabolic acidosis in the first days of life present a challenge in that they will compensate. They will do their best to compensate for their metabolic acidosis. That's normal physiologic compensation. And we keep lowering their target tidal volume because the CO2 is only 35, and that's bad. Yeah, but the pH only 7.32, so, that's okay. And it's probably the pH that matters the most. All right. So if a baby who was pretty comfortable before now becomes more tachypnic and is retracting, baby's obviously telling us something. He's telling us support is inadequate. Doctor, I need more help. Babies are very good communicators. We just need to learn to speak their language. If the baby's oxygen requirement is rising, we probably don't have sufficient distending pressure, right? And then we're developing some atelectasis. And my favorite, the baby's fighting the ventilator. That gas is bad because the baby's fighting the ventilator, so we'll knock him out. Now, the baby's quote unquote fighting the ventilator because inadequate support. That usually reflects air hunger. There are occasional babies who are cranky, especially the older babies, but usually you can get them settled down if you just give them adequate support. So lots of things baby can tell us. The graphics can tell us lots as well. Not if the baby is very agitated. We need to get him settled down because there's going to be a lot of interference. But if you know what to look for, if you have a baby who's relatively quiet, you can learn a lot from watching those waveforms, especially the flow waveform. So that'll tell us about adequacy or excessiveness of inspiratory and expiratory time. It will tell us about, of course, tidal volume that is displayed. It'll tell us about highway resistance and other things. So some examples. So this is important, and I always am amazed that information is often in front of our eyes. We don't always look at it. So here is an example of the expiratory time being too short, right? There's still ongoing expiratory flow when the ventilator cycles on, shown here with the arrow below the line. And also the inspiratory time is insufficient because there's still a lot of inspiratory flow going on when the ventilator cycles off. So this is a baby with relatively high airway resistance. And so we can adjust inspiratory and expiratory times based on the flow waveform, and we always should do that. Again, inspiratory time needs to be tailored to the baby. It reflects time constants. Little babies with stiff lungs have very short time constants. Air gets in and out really fast. So they need a short inspiratory time, often, as short as 0.3 or even a little bit less than that. Older babies with increased airway resistance need a longer both inspiratory and expiratory time. And you can see in the further down to the right that inspiratory and expiratory times have been increased, and you can see the difference in the shape of the waveform. So important information. The other thing to keep in mind is that the tidal volume that is generated is the result of the baby's effort along with the ventilator-generated inflation pressure. In other words, the machine pushes, that's the green portion over here, pushes gas in, and baby pulls or sucks gas in, generates negative inspiratory pressure, and it's the sum of the two that generates the tidal volume. Of course, the contribution of the baby is not measured. So the lung mechanics numbers, the lung compliance that you get in an actively breathing baby, that's bogus because it's not measuring the baby's inspiratory effort. So those numbers are somewhat fictitious, but the shape of the waveform is very informative. But this is why tidal volumes will fluctuate. This is why with inconsistent respiratory effort on the part of the baby, they'll always be perturbing the equilibrium. The tidal volume will average exactly what you said, but it will fluctuate around that target because the baby's contribution is inconsistent. And so I drew in by hand here in this cartoon the baby's spontaneous effort, which you don't see, but which interacts with the machine. So this is just simple assist control, so fixed peak pressure. But the tidal volume is going to be a little bit variable because the patient's contribution is a little bit variable. And with volume guarantee, the machine has to continuously adjust the inflation pressure because the tidal volume is being perturbed by the baby's effort. You might also see something like this on a baby with volume guarantee. If you should always look at the flow and pressure waveform on a baby in VG. This baby is on VG, as you can see, and some of you, I'm sure, recognize that what this means is the tidal volume that the clinician set is below the baby's needs. Recall that, of course, the way volume guarantee works is if the tidal volume measured is greater than the target, it will reduce the pressure, and it will continue to reduce the pressure all the way down to PEEP as long as the tidal volume is greater than what you asked for. And babies, if they're vigorous enough, can, at least for periods of time, generate a sustained tidal volume above the target, and they will end up getting no help from the ventilator. Our RTs keep saying the baby's CPAPing himself. Baby's essentially on endotracheal CPAP, and of course they will either tire out because they're breathing through a narrow endotracheal tube. And so if you see anything like that, you need to make a judgment as to whether this baby is just telling you that he or she is ready to be extubated because clearly they're able to generate a good tidal volume. But you need to see, all right, is this baby tachypnic? Is this baby retracting? Is the oxygen requirement rising? If that is true, then the baby needs more support. If, on the other hand, the baby looks comfortable, is not particularly tachypnic, and the oxygen requirement is low, for heaven's sakes, pull the tube. So again, we have to put it all together, but this is an important piece of information. So you should always be very focused on observing the ventilated waveform. You don't need very many blood gases for babies on VG. In fact, we usually get one a day because your PCO2 is going to be stable as long as you're allowing the machine to do its job. And but you need to be mindful of what's going on with the waveform. I will share with you a little bit of data. We did this survey a couple of years ago. One of our fellows did this to try to get a handle on why is such poor penetration. And I'm not going to present the data about the penetration. Suffice it to say that it's variable. It's only about 50% in the US compared to 95% in Canada. So the Canadians are ahead. But what I'm going to use this for is to illustrate or to pose some of the issues or questions, and you can answer. This is not, we don't have interactive thing here, but we're going to simply have you think about it and answer for yourselves, or whisper to your friend which you think is the correct answer. Simple question. Which baby will need a larger tidal volume per kilo? Same diagnosis, same age, but this baby is twice as big as that baby. Who will need a bigger tidal volume per kilo? And we asked that question in the survey because we wanted to understand what the barriers are. And one of the findings clearly was that one of the barriers is a poor understanding of the principles. And so I will show you that majority of people, answered 5 per kilo was the right tidal volume for a 500 gram preterm infant, but that in fact is not the right answer. Published evidence tells you that it's really more like 6 per kilo. So the smaller baby in that question is the one that needs a larger tidal volume per kilo, and you might wonder why. And here are the data from more than 10 years ago. We did an observational study looking at a bunch of babies less than 800 grams who were on volume guarantee. And we wanted to know what tidal volume they needed when their PCO2 was in the target range, a relatively normal PCO2, plus or minus a little bit. And what we found, as others have, that the small preterm babies typically need a tidal volume around 4.5 to 5 ml per kilo. The extremely low birth weight infants. But when you get down to the other extreme, the ridiculously low birth weight infant, around 400 grams, that tidal volume is closer to 6 per kilo. So around here, 500 to 400 to 500 grams. These are mostly IVGR babies. But the point is, you might wonder why. The reason, the explanation is that flow sensor, which is essential for synchronization and for tidal volume measurement, nonetheless does add some dead space. And it's the same size, about 0.7, 0.8 ml, whether the baby weighs a kilo or weighs 500 grams. So it's proportionately contributing more to instrumental dead space the smaller the baby. So while it's counterintuitive, and some people thought that you should use a very small tidal volume to be gentle on these very small babies, the opposite is in fact true. It's only a relatively small increase, but it is essential to adequately ventilate. There was a study published out of England that concluded that BG didn't work in babies less than 26 weeks because they had everybody on 4 per kilo, and that just won't work for a baby that's less than 700-800 grams. So that's important to keep those differences in mind. One size does not fit all. Similar sort of question. Different disease, same size baby, same age. One has RDS, one has meconium aspiration. Which one do you think needs a larger tidal volume per kilo? And you either know this answer or not, so we'll move ahead. Now, sadly enough, in that survey, pretty much everybody said 5 per kilo. Well, not everybody, but the majority said 5 per kilo. And again, that's not the right answer. It turns out that it's 6 per kilo. And the reason for that is increased alveolar dead space, wasted ventilation. It's a different disease, right? So these babies tend to have a lot of air trapping and therefore increased alveolar dead space. And the data were published 5 years ago. Similar sort of data collection. We looked at a bunch of babies. These were babies with late preterm infants, larger preemies with homogeneous lung disease. And the babies with classic meconium aspiration syndrome with hyperaeration and air trapping needed not only larger tidal volume, substantially larger, but they were also more tachypnic. So their minute ventilation was even more dramatically increased relative to the controls. Yet their PCO2 was identical. Okay, so minute ventilation is over 40% higher in meconium aspiration in order to achieve the same PCO2. So alveolar minute ventilation must be the same. The difference is wasted ventilation. So different disease requires different consideration. And again, if you were to pick a tidal volume that's too small, if you're not sure what the tidal volume is, ask the baby, because the baby will tell you if you listen. The baby will try to breathe higher than what you allowed. All right, another question. Now we're dealing with the same baby to begin with, 650 gram 24 weeker, but here one is 2 days old and the other one is 3 weeks old, and which one will need a larger tidal volume to achieve normal PCO2? And again, you probably know the answer, but anybody who has not familiarized themselves with that part of the literature, here we are. The respondents mostly got it right this time, but many still didn't. Many were still way too low, but the correct information, again, in this instance is 6 per kilo, measured at the airway opening. Measuring the tidal volume accurately is, of course, only possible at the airway opening. So the Draeger ventilator does it right. Some of the other machines on the market don't. So 6 per kilo. And again, here are data published in literature. This was something we looked at. The same group of babies we started with, less than 800 grams. If they remained ventilated for up to 3 weeks, what happened to their tidal volume? Well, we allowed PCO to gradually rise, as you would with some degree of permissive hypercapnia as these babies are getting older and able to compensate. But despite that, they needed progressively larger tidal volume of around 6 ml per kilo by 3 weeks. And you notice that the standard deviation is quite a bit larger, meaning more heterogeneity. So that's it's something to keep in mind. We need to remember to adjust for weight gain as well. So babies, we adjust fluids and drug doses. We need to also adjust tidal volume as babies grow if they remain ventilated for an extended period of time. But beyond that, we need to also recognize that we need to adjust for evolving chronic lung disease. And this probably reflects, again, some degree of wasted ventilation and also some tracheal distension. So to wrap up some of these concepts, we need to begin as soon as we can after initiation of ventilation, because that's when lung compliance changes most rapidly. So I advocate starting right away, especially when you're going to be giving surfactant. Picking the right tidal volume is the key to getting it right, to getting optimal support, getting optimal results. So most larger preemies will do fine with the tidal volume somewhere around 4 to 5 ml. But as I just showed you, the really tiny infants, babies with different disease, older babies need a bigger tidal volume. And that's just something that's really important to know. But recognize that these values I'm giving you, those are means. No two babies are exactly the same. So they're good starting points. But you then have to evaluate the baby's response and adjust depending on what the baby is trying to tell you. Sometimes you pick a tidal volume that seems appropriate based on these data, and the baby is really hitting unusually high peak pressures. And then you have to do a couple of things. One, you need to make sure the endotracheal tube is not in the right mainstem bronchus, and you're not trying to put 5 ml per kilo into one lung. That's important. The other thing you need to do is reassess whether you really need whatever tidal volume you chose, because in some babies, that's just more than that particular baby needs, and you may have to compromise a little bit. So, these are means, averages. Babies are different. We advocate, and we've shown that it works better when you use assist control of pressure support, because every ventilator breath is subject to a volume regulation, whereas with SIMV, only the SIMV inflations are. And because of that, they tend to need somewhat larger tidal volumes. It's important to keep the pressure limit reasonably close to your working pressure so that you get that alarm if the baby's condition change significantly. And if you're now hitting up against that pressure limit where you weren't before, it means something has changed. You need to talk about the pressure limit, but also the actual working pressure. So it's always, which of course fluctuates, but the range is important. And if the baby's compliance improved and the pressure limit was set at 30 yesterday, and now the baby's only using 18 to 22, you need to bring down that pressure limit so that you don't lose that ability to get early warning if things have changed. And then, of course, self-weaning. I understand some of you like volume, like high-frequency ventilation in these tiny babies. For those, I have some hopefully good news. Is you can hope if the FDA approves it. The rest of the world has this already, but the BN500 is capable of high-frequency ventilation. We did a large study a few years ago. It's still being submitted to the FDA, showing that this really works beautifully. That's just to titillate you briefly, and we're not going to go into any data, but the point is you can have the cake and eat it. My beef with the Sensormedics HFOV is it's a dumb ventilator. It doesn't tell you anything. It can't measure tidal volume. It can't control tidal volume. The Traeger gives you volume guarantee with high frequency ventilation. What's not to love? This is awesome. I love it. Hopefully the FDA will give it to us. All right, what about weaning? Last question. What about how do we get this kid weaned? And you know the answer. It's obviously not correct, right? We don't keep lowering the tidal volume because that'll just push the baby over the brink. The pressure comes down automatically. Here is some data from Eduardo Bancalari's group many years ago where they took a bunch of babies that were close to extubation. They were on SIMB. They looked at the contribution of the baby versus the machine in red. And when the babies were on SIMB, where typically the tidal volume is about 6 per kilo, this was not pressure, not volume guarantee yet. Then they switched them to volume guarantee at 4.5, which is a reduction from the usual 6, and bingo, right away, the babies had to work harder. Spontaneous contribution went up quite a bit because the tidal volume was below what they typically need with their low rate SIMB. Then they lowered the pressure the tidal volume some more, and babies were basically doing all the work. They were, as we say, CPAPing themselves. So not the right strategy. This is again what you would see. And you don't want to allow that situation to persist for very long because babies will become exhausted. Either give them more support or extubate them. And so self-weaning, that's one of the neat tricks. It happens overnight. You don't have to stay up. You don't need to get a bunch of blood gases as long as the tidal volume is relatively appropriate, low end of normal for the particular baby. And that you know that if the baby is still receiving significant support, but is making a good contribution. If the tidal volume is set too high, the baby won't have a respiratory drive. Obviously, it's not going to wean. So you need to challenge them a little bit, but not to the point where you are compromising their ability to compensate. So the increased work of breathing is something to avoid, and then you get to some extubatable criteria which you have in your mind, and usually can extubate. So a lot of information. Obviously, we're talking about preventing BPD, so it begins right away in the delivery suite with general support, helping babies establish FRC. Obviously, if we can optimize non-invasive support, we don't have to intubate babies. There's a lot of interest in less invasive surfactant administration, nebulized surfactant, all kinds of ways that will reduce the need for positive pressure ventilation. But if we have to, we have to. Avoiding volume trauma is obviously important. Volume guarantee is a very good way of doing that. We need to, however, also ensure optimal distribution of that tidal volume using adequate and expiratory pressure, but remembering to wean it when appropriate. We need to know how to pick the right tidal volume. One size does not fit all, and I hope I gave you some useful information about how to go about recognizing what the tidal volume should be and asking the baby whether he or she concurs. And of course, also we need to keep in mind what's going on, what's the disease process, and adjust the overall strategy and respiratory time and such to the underlying pathophysiology. And understanding how your machine works is obviously helpful. And that's all for now. Thank you.